Welcome to Webinar Wednesday. We're excited to have over 300 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Before we get started with today's presentation, we do want to give one lucky attendee an ice cooler for answering this week's trivia question. Today's sponsor, Bayer Multi-Vendor Service, is headquartered in Pennsylvania. Which city was the Declaration of Independence signed in 1776? You can answer now using the questions feature on your dashboard. While you're answering, I want to invite everyone to join us for the 4th Imaging Conference and Expo, which will be held July 24 and 25 at the Hyatt Regency Hotel near Washington, D.C. The ICE conference will bring over 400 imaging service professionals from across the nation for 2 days of learning, networking, and the latest advances in imaging. Registration is now open. You can receive complimentary admission by using the VIP Pass compliments of Bayer Multi-Vendor Service. And you can find this VIP Pass in the Webinar Wednesday workbook that was emailed out earlier today, or you can download a copy on your webinar dashboard under the handout section. To find out more information on the ICE conference, please visit attendice.com. All right. Let's see who the winner for this week's trivia question is. Walter Sierro. Congratulations, Walter. The correct answer was Philadelphia. Webinar Wednesday would like to thank our sponsor, Bayer Multi-Vendor Service. Bayer MVS is your trusted provider for MRI coil, ultrasound transducer, CR reader, and dry film printer repair. With exceptional repair capabilities, quality solutions, and dedicated customer care, Bayer MVS provides excellent value and third-party service. For more information on this company, please visit mvs.bayer.com. Our presenter today is Ted Lucidi, Technical and Clinical Specialist for Bayer Multi-Vendor Service. Ted has over 25 years of experience with diagnostic ultrasound within the clinical environment. He currently provides custom training and support of diagnostic ultrasound, MRI coils, and computerized radiography. Ted, you may begin whenever you are ready.
All right, thanks, Jamie. Hi, and thanks for attending this afternoon, guys. I want to thank you for joining in, and I really want to thank Tech Nation for the great opportunity to reach out to all you all. I'm really excited to share this information with everyone because it really has the potential to significantly decrease your service spend on T-probes. I wanted to share a quick bio, really just because it sets the stage for today's webinar. Like Jamie said, I've been supporting ultrasound for over 25 years, but it's my clinical background that brought this thing to development because I have more than 20 years servicing as an in-house engineer at a Pittsburgh hospital. In 2006, I made the transition to Bayer Multi-Vendor Service to manage our repair shop. And in 2010, we actually created the position I'm in now where I focus on training, as well as assist our customers with actually reducing their need for our services. I really have a passion for the service industry, and I really hope that it comes evident through this presentation. For those of you that might not be familiar with Bayer Multi-Vendor Service, Jamie did do a great introduction there, but we started about 30 years ago servicing MRI coils. In 2001, we launched into ultrasound probe repair and have repaired well over 50,000 customer transducers in the last 10 years. In 2007, we expanded with a field-based service team for computerized radiography and imager systems. We're only one of a few ISO 13485 certified repair providers in the industry, and we do perform repairs for several medical device manufacturers. ISO 13485 certification has really come to the forefront in the repair industry lately, so I wanted to take a minute and talk about it, and it's come to the forefront for a very good reason. Currently, there are really no standards or guidelines that regulate the repair of a medical device by a third party. This means that a third-party repair provider has the freedom to repair a medical device as they see fit. And that can be kind of scary. 13485 is a quality standard specific to the servicing and repair of a medical device. It's a set of practices based upon the FDA's good manufacturing practices that requires accountability, compliance with federal regulations, maintenance of documentation, traceability of repaired products, continuous quality improvement, as well as risk management. Since Bayer Radiology, former MedRad, is a medical device manufacturer, it just made sense that our multi-vendor service division be held to the highest quality standard. So there have been many webinars and presentations on topics surrounding T-probes. Most of the previous presentations, mine included, have focused on really what is a T-probe, how they work, as well as how they fail. None have really taken a systems approach or a holistic view, or have really addressed the true root causes. This afternoon, I'm going to take you on a journey through a day in the life of a T-probe. So from a context point of view, we do have to discuss the common modes of failure that you may have heard before, but we'll do so only to concentrate on a root cause analysis from a clinical point of view. I'll briefly present some proven methods for reducing costly failures, but I really want to focus our time on relating the common failures to the root causes. We'll see that gaps in the care and handling process are truly the sources that lead to costly failures. We're going to plan for a successful gap analysis. I'm going to take you through the process that we use when we go on site, and I'm going to present you with techniques for compiling a report to key stakeholders. So over the next 45 minutes or so, I'm going to make you the expert in process analysis. So really the overarching goal for today's session is for your facilities to reduce the frequency of and the severity of catastrophic or costly T-probe failures. We're also going to raise some awareness to the common modes of costly failures as well as the root causes. But if some of you aren't familiar with the cost of replacing or repairing these T-probes, we're going to enlighten you a little bit on this. So replacing one of today's costly 3D T-probes from a manufacturer can approach $30,000. So that same probe on the used third-party market may approach $28,000. So even repairs for these complex 3D T-probes can range anywhere from $500 to well over $10,000. So by identifying current and industry best practices, as well as implementing process improvements, the plan would be really to move you all from costly replacements to manageable preventive repairs. So Bayer Multi-Vendor Service piloted today's program back in 2009 with a single customer request. This customer owned 10 T-probes, yet experienced 28 catastrophic failures in a single year. So after we went out and did our process analysis, identified some root causes, and they implemented only a few of our suggestions, that customer experienced an immediate result that led to a 50% decrease over the first year. The graph shown really illustrates that over time, significant decreases were, as well as still are, being realized. Since 2009, we've performed over 100 of these educational sessions, and customers really truly see the value in this service offering. Again, the desired outcomes for today's session are that you, not me, but you, will be able to identify key points in your care and handling process. You'll be able to identify gaps in the process by comparing the current process to the industry best practices. We're going to have a call to action for you to provide recommendations to department managers so that your facilities can realize significant reductions in catastrophic failure rates that will lead to substantial cost savings. So let's jump in here. If we list the most common modes of failure, they can really be divided into three categories with several overlaps. Now, obviously, we have the physical, the mechanical, as well as the electrical, and those overlaps are the electromechanical and the calibration failures and some damaged acoustical array. So the highlighted modes of failure that I have here are what you can expect to encounter over the normal life cycle of a T-probe given proper care and handling. Some of these failures, despite the best care and handling practices, will be ever present. Every electromechanical device ever created undergoes some level of wear, and almost every electromechanical device should undergo some level of preventive maintenance. So catastrophic failures are extremely common to T-probes. Catastrophic failures can really be defined as massive electromechanical failures resulting from gross fluid invasion. So one of the most common failures on the Philips X72T is a deteriorated seal surrounding the acoustic lens. If not identified and addressed prior to submersion and disinfection, this could result in gross fluid invasion and massive electronic failures. You can see the grayed out areas around the brown square acoustic lens on the distal tip. That's a point of entry for some gross fluid during the cleaning and disinfection cycle. Two common points of failure across all makes and models of T-probes are separated collars and separated seams on the distal tip. The collars, or some people call them glue beads or adhesive beads, the collar is a group of materials designed to adhere the bending rubber to the tip or to the tube, and is really designed to provide a watertight seal between these various components. The distal tip is typically composed of several plastic components which are adhered together to, again, form a watertight seal. Over time, or in combination with trauma, the collars can and will begin to separate from the tip or the tube, and the seams in the distal tip can also separate, and that in turn allows fluid entry during use, during gross cleaning, or disinfection. One thing to think about is these failures can also provide a means of harboring bacteria and could be a potential source for cross-contamination. Disinfecting a probe through immersion with a separated collar or a damaged distal tip is really another root cause of gross fluid invasion. So although not as common, a cut or a damaged insertion tube can be another source of gross fluid invasion. By far, the bending rubber is the component that is most likely to fail, resulting in gross fluid invasion. So the bending rubber is constructed of a very thin, very flexible material. So it will become more and more brittle with age and more brittle with continued disinfection cycles. Holes that are barely visible to the naked eye will be a source of gross fluid invasion. So probe manufacturer, let's jump back there. Let's say it's common for the distal tip to become scratched over time as a result of continued normal use. That tip is going across the molars, across a bite guard. It's maybe impacted during some cleaning and handling sessions. So you can expect the tip to become scratched over time. But deep gouges and cracks resulting from trauma, in combination with the disinfection process, can also result in these costly catastrophic failures. So probe manufacturers are pretty clear in detailing which portions of their probes are and are not able to be exposed to fluid, as well as which sections are submergible. So another popular mode of failure is fluid invasion to what we call the control housing. Once fluid enters this area, that fluid is free to migrate to any interior portion of that probe. We've seen probes that have been fully flooded the whole way from the tip to the connector. We've had fluid and disinfectant dripping out of the connector pins. All right, so it's possible to classify the common sources of catastrophic failures into three groups. Let's look at those. So we have some of those that are attributed to normal wear. Some of those are attributed to trauma, and some of those can be attributed to either gaps in training or gaps in a process somewhere. Visual inspections, leakage testing, and preventive maintenance really provide the ability to detect these failures. And really what I'm trying to say is costly, catastrophic failures are highly, if not fully, preventable. So, unfortunately, most T-probes are kept in service until a major failure occurs. Knowing that catastrophic failures are preventable, let's look at some of the root cause analysis of each of these types of classifications. Like I mentioned, wear and tear is always going to be present. Your tires are always going to wear on your car. You always have to change your brakes. Same thing is true on a T-probe. Your bending rubber is always going to wear. The seams on your collars, on your bending rubber are going to separate over time. The seals are going to degrade on not only T-probes but standard probes as well. So gross fluid invasion as a result of missing seals or separated materials is really a direct result of a gap in some kind of periodic inspection. Let's take us to the next level. So we're all human. Accidents occur. They can occur. They will occur. That's just the nature of our humans. But gross fluid invasion as a result of damaged components is a direct result of trauma as well, or in combination with a lack of some type of periodic inspection. The next thing is employee turnover in some roles can be quite common, but there's also a need for continuous education. Gross fluid invasion to the control housing or the connector itself is really a direct result of some type of gap in end user training or some type of gap in the process itself. All right, so as mentioned earlier, bending rubbers are going to wear out. They're going to become more brittle with age and more brittle with chemical exposure. Seams and seals will continually degrade. This is an excellent example of a device which would benefit from being added to a PM program. I only know of a handful of facilities that have their T-probes on a PM program. But there are modes of failure that do occur out of what can sort of be considered normal use or normal wear. In these instances, that's where the process gap analysis will really help you identifying the root cause. Implementing controls, implementing process improvements will potentially reduce the failure severity and ultimately your costs. So one of the most challenging parts of doing or performing a process gap analysis can be overcoming objections. overcoming injections can be one of the largest stumbling blocks. In general, most people, most users would agree that they're following proper care and handling practices, and really any of the failures that have or are occurring are really just out of their control. Another portion of the population may believe that their level of tenure, their level of experience provides some credibility to the process that's currently in place. Really, the truth is that there have been a lot of recent developments in tools and techniques to really help with and aid with proper T-probe care and handling. Another point to note is that probe designs have recently become more complex. And that really translates into what may have worked before may not be as effective now. It's time for a change. It's time to revisit the process. What can we do better? So the challenge with T-probes and reducing failures is that T-probes pass through so many hands. There's really no single entity in a hospital setting that's truly responsible for the entire process. Ultimately, success really begins with identifying and understanding all of the different steps in the process. And really, until that occurs, failures can and will continue. All right, so let's take a journey. Let's take a look at the typical day in the life of a T-probe. Where does it go? Where does it end up? How is it used? What happens? I'm going to use a probe that is used in an OR environment because they're subject to the most complex process of anywhere in the facility. Granted, some of you have probes that are isolated just to echo lab. Some of the probes in echo lab are transported to the bedside or the ICU and brought back. But really, it's the OR that poses the most challenge because there are just so many hands in the pot. So we're going to start the day with someone retrieving the probe from storage up at the top there. From there, that probe is transported to an OR, where it's dropped off. It's staged for use. Maybe that probe is delivered to a circulating nurse. Maybe it's just draped across the scanner, or maybe it's hung from an IV pole. Next, when it's ready for use, it's in an OR, it's usually an anesthesiologist, a nurse anesthetist, or a cardiac resident inserting the probe and performing the scan. Very few cardiologists or echo techs actually insert and operate the probe during an OR case. Yes, there are some of those facilities that do have those attendings that are supervising, but in those teaching facilities and busy facilities, it's often delegated to other personnel. So upon completion of the scan and extraction, the probe may be handed off. It might be set aside or placed within a bag or a bin. So the probe may sit idle for an hour. It might sit there for a minute. But really, it's going to sit idle until someone can retrieve that probe for cleaning and disinfection. So the next stage is what we call gross cleaning. And gross cleaning may occur within the OR, or the probe might be transported to central processing for gross cleaning. And really, all gross cleaning merely involves removing of body fluids from the probe through a rinsing process. It's usually done in a scrub sink, and the probe is just grossly rinsed until there's no blood or body fluids left on the product. So, once the gross material is removed and the probe is wiped down, then it's taken to be disinfected via submersion. So there are several methods of disinfection, ranging from soaking in a bin or a basin to immersion in a tube system or placement within an automatic disinfection machine. There's really no method which is more effective than another. The differences between the different processes really present themselves through efficiencies and ease of use. So once the probe is disinfected, it's once again transported to its place of storage. Now, whoever's transporting that probe, they may just deliver it to a specific location. They may hand it off to a particular individual who's responsible for moving that probe into storage. So looking at this process, I see at a minimum 4 different people, up to a maximum of 8, are touching this probe during a single use in an OR case. In the last 5 or 6 years, 7 years since we've been doing this, our data shows that on average, it's about 6 people across 3 cross-functional teams that are touching or are responsible for the proper care and handling of a single probe during a single use. All right, so let's take a deeper dive into this now. Taking a closer look, I've highlighted some of the points of the process at which a probe might undergo some traumatic damage. So it can be seen that there are multiple points where the probe is being transported. There is also temporary storage or staging. There's insertion as well as extraction. So many people believe that biting of a T-probe is the primary cause of traumatic damage. And the use of bite guards will prevent the trauma that occurs to T-probes. And really, our data shows that it's more due to poor transportation and setup practices than anything else. This data is even more supported of probes that are used in OR environments because patients who are undergoing OR cases with T-probes are fully anesthetized. Therefore, there's little to no gag reflex that's going to cause the bite to occur. All right, so although wear and tear are continual and accidental trauma as well as gross trauma have the opportunity to occur at multiple points of the process, it's really the act of disinfecting a probe, a damaged probe, either in water or chemical disinfectant, that introduces or induces the costly catastrophic damage. So really a quick overview of documentation from multiple probe manufacturers provides some really consistent messaging into the proper care and handling of a T-probe. You know, if we combine this with information from vendors or suppliers who manufacture devices designed to enhance T-probe care and handling, we have some really powerful tools. So let's highlight some of those. So performing a quick visual inspection each time the probe changes hands. So although very popular, do not use bags or pillowcases to transport T-probes. It's really suggested that you use some type of transport bin or surgical tray for transporting really any length of distance, even if it's from one room to the other. And also use the rule of one probe to one bin or tray. Another important feature is to not stack anything or place anything on top of a T-probe. Some type of tip protection should remain in place at all times except during insertion. We'll talk a little bit about that in a few minutes. It's really critical to perform a thorough visual inspection prior to performing a leakage test. So now we're down into central processing, where the probe is going to be high-level disinfected, if not gross cleaning. These folks have the critical role of performing a thorough visual inspection. A leakage test is really designed to find the holes that really can't be visualized with the naked eye. And it really needs to be performed right before disinfection. There's no There's no benefit to performing a leakage test after the probe has soaked in disinfectant for 50 minutes or 15 minutes. If a hole is found or if a leakage test fails, you don't want to continue with the normal disinfection process with immersion. You do want to disinfect with some kind of wipe system. And you definitely want to remove the probe from service. And really, a final step is to perform a quick functional check prior to returning that probe to storage. So really, each and every part of this circle has a point of inspection or a process that can aid in the care and handling of these probes. All right, so planning for success involves really engaging managers as well as directors, and really many even go as far up as the C-suite. You know, getting your CFO because he's the one paying the bills. So in this scenario that I developed, I show 4 different cross-functional teams. Each team is being managed by 4 separate individuals. So we have central processing, we have the OR personnel, we have the echo lab personnel, and we have some folks in anesthesia. Each area has its own set of policies and procedures that have waterfalled down from the business decisions made up at the director level or even higher. So external to this is the process or the team who's really responsible for getting these things repaired or replacing the T-probes. And I just show them as the clinical engineering department. After all, you guys pay for everything anyway. You fix everything. You guys are the heroes. In the case of our pilot program that we did back in 2009, the excessive costs were the burden of the clinical engineering department. So the costs were really used to drive the decisions that really helped to revise policies and procedures, which then waterfalled down to ultimately affect the operations. So really, for true success to be realized, it has to be a top-down approach. Addressing a T-probe failure at a single point of the process is not going to solve the problem. It really has to come from a top-down approach. All right, so moving on with some process analysis or process improvements. So what I have displayed there on the screen is one type of model for what they call continuous quality improvement. CQI, or continuous quality improvement, employs 4 different areas: plan, do, check, and act. So in our exercise here, in our process analysis, we're going to plan by defining in your facility the who's, the what's, the where's, and the why's. I don't know your facilities because I've never visited them, but you know the who's, the what's, the why's, and the where's. So we're going to do this by observing each step in the process that I outlined, from the time that that probe is removed from storage until the time that that probe is returned. Next, we're going to check. We're going to check by comparing your existing process with what is considered industry best practices, and then we're going to suggest improvements to the overall process and really to specific groups. Again, everyone has a part to play here. Finally, we're going to act. We're going to act by educating users. We're going to act by implementing changes. And we're also going to revisit this process every so often. Maybe it's once a year. Maybe it's as we see employee turnover. Let's see, and or every so often. So next, I'm going to walk you through each step of the care and handling process. At each step, I'm going to present scenarios which can be scored as green for ideal, yellow for cautionary, or red for immediate action required. So we're all on our best behavior if we know we're being watched, right? So process gap analysis is best performed unannounced in hopes of identifying what I'd call standard practices. Let's start with the beginning in storage. So, is the probe being stored in a bin? Is it in a drawer or a shelf? Is it hung vertically? Is it in a safe, enclosed environment? Is tip protection being employed? So here it can be seen that although hung in a closed environment is good, there is room for improvement. Long-term or overnight storage in a bin, a drawer, or a shelf really requires some action. All right, how's the probe transported to the exam location? Is it hand carried? Is it placed in a bag or a pillowcase? Is the probe inspected prior to use or whenever it's removed from storage? Is the transport bin used and its tip protection in place? If it's hand carried or transported in the bag, there's a definite need for improvement. Ideally, the probe should be transported within a bin with tip protection in place. It's also a good idea to visually inspect the probe prior to each use. Even if the probe is being transported within a bin or a pillowcase, employing tip protection and a visual inspection does make for an acceptable method. So next you'll want to observe how the probe is being set up prior to the exam. Is the probe draped across a scanner? Is it placed within the probe holders on the scanner itself? Is it hung from an IV pole or set on top of another device? Again, is tip protection in place? Ideally, the probe is contained within the transport bin until it's needed. Less desirable, but although effective, is suspending the probe from an IV pole. Combining this option with tip protection does make for an acceptable solution. The probe should never really be draped across a scanner or placed in a probe holder. Probe holders were not designed for T-probes. They're designed for standard probes. One thing to note that I really haven't discussed in this presentation are bite guards or protection during insertion. These devices are really important and their proper use is critical for non-OR procedures. Again, in OR procedures where the patient's fully anesthetized, their use is, let's say, of a less critical nature. What occurs immediately after extraction or during extraction is important. Is the probe merely handed off to someone? Is it set on the floor or on top of another device or table? Is it placed in a pillowcase or a biohazard bag? Is the probe placed in a bin? And again, is tip protection installed? Ideally, the probe is placed within a storage bin with some type of tip protection. The probe should never just be handed off or set on the floor or a table or on top of another device. You're really asking for trauma to occur if one of those methods is employed, especially if tip protection is not used. Gross cleaning usually involves rinsing the probe under running water. And really, again, manufacturers are really clear on what can and cannot be exposed to fluid. So in this part of the process, where's the probe placed during the process? Where's the connector placed? And does a very thorough visual inspection take place? It's really possible for the probe's connector or control housing to be easily splashed or exposed to running water if they're not protected or placed in a safe location. It's recommended that the connector be kept as far away from fluid as possible. Most T-probes have a ring near the control housing, whether it's steel or plastic. This can be used to hang the probe from a wall-mounted eye hook. So you're protecting that control housing from accidental splashage. Again, this is an ideal time to perform a thorough visual inspection. It's the cleaning personnel that play the most critical role in this process. And most probe manufacturers stress this part of the process in bold text in their manuals. So it's the top 6 inches of the probe that really needs to be examined for any area that would even potentially permit any type of fluid invasion. If any area is identified that you might think will let fluid in, the probe should really be removed from service for further inspection. When in doubt, it's always best to err on the side of caution. We've even had some customers use a wall-mounted or gooseneck magnifier to help the cleaning personnel in this task. So at the end of 2015, the IAC established a requirement that leakage testing on all T-probes must occur between each patient study, and that the results of the testing must be documented. Even though it's been well over a year, not all facilities are compliant. And really, if you're not accredited by the AIC or IAC, it's optional. That being said, it's recommended by probe manufacturers that you do perform the leakage testing. And I would expect the Joint Commission to really introduce this in the next year or so. So the questions you're going to want to ask in this part of the process is, really, does leakage testing take place? If so, when is it taking place? And if the leakage test fails, what occurs? It's important to note at what point the leakage test takes place, because it does no good if you've already flooded a probe to then perform a leakage test. So it's best performed at the onset of submersion. It's also important how much of the probe is immersed in the test fluid. Most manufacturers state that the probe should not be immersed higher than the last number that is stamped on the insertion tube. And it's really because that rubber boot is not waterproof that leads to the control housing. One final item is to identify what happens if the leakage test fails. If the test fails, the probe again should be removed from the liquid immediately, thoroughly wiped down with a disinfectant wipe, and removed from service. All right, each probe manufacturer publishes a list of approved disinfectants, and the use of an unapproved disinfectant can void a manufacturer's warranty or coverage under a service contract. Another point to note that each disinfectant has its own immersion time as well as its own rinse time. So the questions are, is the probe being disinfected using an approved chemical? Is the immersion time being monitored, and is it being logged? How do the logged immersion times compare to actually what is recommended by the disinfectant manufacturer? Hospital policy or infection control usually requires logging of disinfection cycles. OEMs usually state in bold lettering that immersion times need to be strictly monitored, and that the immersion time should never exceed what is recommended. With leakage testing, again, the probe should not be immersed to higher than the last number stamped on the insertion tube. More and more options are becoming more and more available to automate the process of disinfection, and the use of something like the TD100 is a best practice, because your times are monitored and logged, as well as the level of the fluid. So finally, we want to observe what happens after disinfection. Again, how's the probe transported? Is tip protection in use? Is it bin being used? Is the probe just dropped off, or does someone check the probe prior to placing it into storage? Again, ideally the probe is transported in a bin using protection, and before being returned to storage, someone takes a final look at the probe. It's a good idea to look at the connector for any damaged pins, wiggle the articulation controls to make sure that it works in all 4 directions. So actually now we've come full circle around the process. Let's look at how we document this, or how we make this whole process easy, or let's say efficient. So when our team performs a gap analysis, we use a form that I created that walks us through each step of the process. And we just have a series of check boxes and areas for commentary. So this can be done very quickly, very efficiently. You can really capture some data easily. It walks us through each scenario and helps capture important parts of the process. You can actually document people's names, who attended, who helped out, what departments were visited. When we do multiple department processes, We'll have one of these forms for the OR. We'll have a different form for Echo Lab because their processes are entirely different. So photo documentation can really aid in capturing good practices as well as those in need of improvement. So here it can be seen that the probe is stored properly and that a tip protector is in place. Here is an improperly staged probe in an OR environment. It's at a risk for some physical damage. One bump into the scanner and the probe uncurls and falls to the floor. So a tube system for disinfection has been around for 10 to 12 years, and they're really still an acceptable tool. The challenge with a tube system is, as mentioned earlier, the level of the liquid needs to be monitored and kept at a safe level. If we looked at the levels of liquid in those two tubes, it's possible for the users to flood a probe and not even realize that it's occurring. They're just immersing the probe in the liquid. So the final step in this whole process is to compile and provide a report to all key stakeholders. The report that really doesn't have to be lengthy, but it should illustrate the current state of the process when compared to industry best practices. You can see where this site has a lot of room for improvement with all the no's, as they only employed 2 best practices. Comparing the current process to industry best practices allows for recommending improvements to specific areas or even to specific managers. It's highly unlikely that any single facility or any single department will be able to implement all of the various recommendations. It's really just prohibitive to the entire process, but really exposing the largest gaps and recommending the improvements. Facilities can pick and choose the items which can really make the biggest impact for the biggest areas of improvements. So we found that the most impactful areas are related to soak times, tip protection, and visual inspections. So soak times really must be monitored. Consider purchasing a low-cost digital timer to help with time management. Consider modifying the disinfection logbooks to enable tracking of information. We created a logbook to help our customers, but you could create your own using Excel. It's not too challenging, but you have a logbook for each probe that passes through the process, and each log sheet captures a specific stage of the process. Once X amount of uses have occurred or processes have occurred, the probe could then be required to undergo some type of preventive maintenance. It can be seen here that there's a sign-off log for each activity, and each sheet can be customized to your individual process. Some type of tip protection, again, should be in place anytime the probe is not within the patient. Single-use options are available from many sources, including Bear Multi-Vendor Service. We do sell our tip protectors, as well as provide them on all of our repaired and loaner products. Some customers have really sought out a no-cost solution. What they've done is wrap the tip of the T-probe with a quarter-folded washcloth, and if they do have to hold it in place, they wrap it with a rubber band. So the greatest impact can be made through thorough visual inspections. I believe in your packets you've received one of our visual inspection guides. We try to have these visual inspection guides posted in the cleaning areas to keep these topics top of mind and sort of give the cleaning personnel an idea of what they're supposed to look for. It's really of vital importance to get these in the hands of the managers responsible for the cleaning personnel. All right, so we've identified some of the root causes of catastrophic failures. We've highlighted some industry best practices, presented you all with some tools and some techniques for assessing the level of care and handling, and really issued you guys a call to action. Keeping all of this in perspective, the money saved by eliminating just a few catastrophic failures in a year can justify the expense of just a single employee managing this entire process. Keep that in perspective. You know, I really want to thank you all for your time and thank Tech Nation for the great opportunity. We're always open, willing, and able to share more information into this and other areas to help you all reduce your costs of whether it's standard probes or T-probes. My contact information is below, and I welcome all of your questions, and we'll reach out to you personally, either voice or through email. And Jamie, I will turn this back over to you.
Perfect, Ted. Thanks. We have received a few questions from the attendees while you were presenting. Just a quick reminder to all of the attendees, you can submit your question anytime. If we're not able to get to it in our 60-minute time limit, I send all questions over to our presenter, and I know Ted's going to follow up with you offline. So keep the questions coming in. But Ted, let's see how many we can get through. First question, you mentioned adding T-probes to a PM program. What interval would you suggest?
So this is a challenging question from the point of view where it really depends on the level of usage. You know, it depends on how many cases this probe is being used in, as well as the level of care in your individual facilities. So again, the bending rubber is the component that's really mostly affected by wear and tear and chemical exposure. And our data really shows that they start to become more brittle after 100 to 150 cleaning cycles. So for some facilities, that interval may span 3 to 6 months. In others, it might be 6 to 12 months. So, you know, really, we try to start customers off with, look at the probe every 6 months at, say, the clinical engineering level. But you're relying on your partners in central processing or Echo Lab to look at these things every time they're in use. You know, send that probe in every 6 months for an evaluation. Our evaluations can be free of charge. We can provide you with a loaner to keep you up and running while we evaluate and assess whether your probe should be addressed at that time. So that's a really great question.
Great. Another one submitted by the attendees. Our T-probes are under contract with the OEM, but why do we still get charged for damaged probes?
Okay, let's see here. This is another tough area. Manufacturers really typically only cover failures associated with normal wear and tear or in combination with some minor physical damage. You know, depending on the contract wording, you know, OEMs or service contracts may cover 1 to 2 service events a year that they deem misuse and abuse. Typically, most fluid invaded probes are considered misused, since fluid invasion is really considered preventable via visual inspection and leakage testing. You know, right now, about 50% of all of our TE probe failures are related to some level of fluid invasion. You know, I typically, this is me, this is not bare multi-vendor service speaking, I typically discourage OEM probe coverage because of this challenging point of contention with what is misuse and what is not misuse. If you see that there's some fluid invasion on this probe, if you see some trauma to this probe, maybe not even try to have it collected under a service contract or warranty. It's probably going to be denied. How about let's go into the next one.
Great. I love this one. Do you have a T-probe loaner program?
Actually, we do. It's one of the things that we think is of a lot of value to our customers, and it's for that reason of we can keep you up and running if you identify a questionable area on your T-probe. Colin, we can have a probe at your doorstep the next morning, ready for use. We can then have you package your probe up in that loaner box, send it back to us, we can have a result of an evaluation in 24 hours, but we have a very, very robust loaner program. Right now, we have over 2,000 probes in our loaner pool right now, so chances are we have one for them.
All right, let's see if we can get through one or two more questions. Do you have suggestions for best practices to keep in mind? Nope, hold on. Do you have suggestions for best practice in keeping the connector from getting wet during the cleaning process?
You know, that's a huge challenge, especially in some departments where there's a confined space to do all this cleaning and disinfection. What we've seen some of the successful customers of ours do is they'll wrap the connector in a towel. Now, disinfection is usually occurring in central processing or in a dedicated area, and they have towels and drapes available. We've had our customers just wrap some type of towel around the connector to make sure it's not able to be splashed or accidentally splashed. But space is a big concern in disinfection areas.
All right, I think this might be our last question, but again, attendees, if you've submitted a question we weren't able to get to, I'm going to send them over to Ted. He'll follow up with you offline. But Ted, how many days should a probe be unused before it needs to be reprocessed?
Oh, that's a good one. This really goes down to the policy in the hospital, you know, in that facility. You know, it's really best consulted by the infection control folks. Sometimes just having the probe hanging in a cabinet, even though it's isolated, you know, after a week, the probe can become sticky just from contaminants or whatever, you know, air is flowing through that area. It all depends on the manner in which the probe is being stored. I don't know who the manufacturer is off the top of my head, but they make storage cabinets that are positive pressured, so it pushes out any contaminants. So I would say if probes are kept in that type of environment, the need to reprocess an unused probe would be minimal. If a probe is left hanging in an open area, I wouldn't want to let that go more than a day, just because of all the traffic going in and out of an area. So it's really subject to the actual environment. And I like to see those so I can give advice or recommendations for that particular facility.
Perfect. Well, Ted, you have quite a few questions coming your way. We're going to send them over to you shortly, but I want to take some time to not only thank you for the time and presentation today, but to give a big thank you to our sponsor, Bayer Multi-Vendor Services. Again, their website is mvs.bayer.com. One lucky attendee will win an Amazon gift card for completing the post-webinar survey, which is going to appear on your screen shortly. You do have to complete the survey to obtain your certificate of attendance, and if you don't see the survey, please email us at webinar@mdpublishing.com. We send these certificates via email within 7 business days. We do have a webinar every week at this point for the rest of May and June. You can see a complete calendar at onetechnation.com/webinars. All right, guys, enjoy the rest of your afternoon. See you back next week at 2 p.m. Eastern.